My name is Georgiana Wilton, and I'm a scientist at the University of Wisconsin, Department of Family Medicine. This presentation is second in a series of podcasts based on the Fetal Alcohol Spectrum Disorders Competency-Based Curriculum Development Guide developed by the Centers for Disease Control and Prevention. The goal of the series is to educate medical and allied health providers about the prevention, identification, and treatment of fetal alcohol spectrum disorders. This second podcast provides information on screening and brief intervention for women. Podcast number 2 covers alcohol use by women, drinking guidelines, screening and brief intervention, and resources for more information. How many women use alcohol? Over 50% of U.S. women ages 18 to 44 use alcohol. Nearly 33% binge drink, and women who binge drink are at increased risk of an unintended pregnancy and alcohol-exposed pregnancy. As a matter of fact, about 10% of pregnant women report using alcohol, with 2% drinking excessively. So how much alcohol is too much? For women, the guidelines are no more than 7 drinks per week, no more than 3 drinks on any day, and no more than 2 days per week, staying below the 7-drink cutoff. And of course, no drinking if you're pregnant, breastfeeding, planning to become pregnant, or sexually active and not using contraception. It's important that everybody knows what is considered a standard drink. 12 ounces of beer or a wine cooler, 8 to 9 ounces of malt liquor, 5 ounces of table wine, 1.5 ounces of brandy, or 1.5 ounces of spirits. But it's fairly simple to compute what a standard drink is. We know that 0.6 ounces of absolute alcohol equals 1 standard drink. So you can look at the percent of alcohol in the drink you choose times the volume, divide that by 0.6, and you'll have the number of standard drinks that represents. So let's look at an example. A 40-ounce malt liquor at 8% alcohol. We take the volume, 40 ounces, times the alcohol, 0.08, and we have 3.2 ounces of alcohol. Divide that by 0.6, our number in a standard drink, and that gives us 5.3 standard drinks. Alcohol does not affect women and men the same way. Women tend to absorb more alcohol and take longer to break it down, and these differences are due to body structure and chemistry, the differences between men and women. We know that alcohol can have a dramatic negative effect on women, including health risks, including liver disease, increased risk of cancer, weight and nutrition issues, mood disorders. There are safety risks, including an increased risk of sexual assault, and reproductive risks, decreased fertility, or the risk of an alcohol-exposed pregnancy. What are the risk factors associated with risky drinking? Ethnicity and acculturation, lower socioeconomic status, age at first drink, we're looking at anything below the age of 14, genetic predisposition, depression and other mood disorders, marital status, heavy alcohol use in partner or other family members, use of other substances, abuse, and multiple sex partners. So how can you identify and help female patients with alcohol use and abuse problems? You'll want to screen and intervene. So who should receive screening? Really, we're looking at all women. Women of childbearing potential, women who are sexually active and not using birth control or not using birth control effectively, pregnant and postpartum women, high-risk female drinkers. We want to basically go towards a routine alcohol screening for all. Guidelines should be, first of all, defining what a standard drink is, assessing quantity and frequency, how much and how often is a woman drinking. We can look at average or typical consumption patterns using methods such as the timeline follow-back. We want to note binge patterns, and for women it's anything more than 3 drinks, so 4 or more drinks on any occasion is considered a binge. We can look at scores from screening tools, and we can assess adverse events. These kinds of things are health issues, accidents, unwanted sexual experiences, and legal implications. There are many screening tools available. We can look at the timeline follow-back, which is a 30 or 90-day follow-back calendar, trauma questionnaires, the UCLA alcohol screener, or the short questionnaires that we'll cover briefly, TACE or TACE, the Tweak, Audit, or the Cage. I'll review the short screens, and you'll notice they are variations on a theme. The TACE or TACE looks at tolerance. How many drinks does it take to make you feel high? Have people annoyed you by criticizing your drinking? Have you ever felt you ought to cut down on your drinking? Or an eye-opener, have you ever had to have that first drink in the morning? The Tweak looks at tolerance as well, worry or concern by family or friends, again that eye-opener, or blackouts or amnesia while drinking, or the self-perception of the need to cut down on alcohol use. The AUDIT-C looks at drinking during the last 12 months, how many drinks do you usually have on days that you drink, or how often in the past 12 months you had 5 or more drinks on a single day. For women, we also want to look at how many times they had 4 or more drinks on a single day. This information can also be gathered using the timeline follow-back method. The CAGE, which is commonly used although not recommended for women. Have you ever thought you should cut down on your drinking? Have you felt annoyed by others? Have you ever felt guilty? Or do you need that morning eye-opener? Again, sensitivity and specificity just doesn't hold up for women, and this is not recommended for their use. There are some cautions in scoring that must be noted. A safe dose or pattern is not considered consistent across individuals. We have to take into account other risk factors, including health conditions and medication use. Scoring options should be viewed as guidelines only. Even low dose or moderate alcohol use can be of concern to individuals with certain medical conditions and taking certain medications. In conducting screening with women at risk, I've heard many rationalizations, but I dilute my shots by adding orange juice so that the alcohol really isn't bad for me. Or, no, I don't drink alcohol, only beer. You might also hear, Long Island iced tea doesn't really count, right? Or no, I've only had 1 drink and I hardly ever finish the entire pint. So what are the options to address alcohol use with patients? There are many options for treatment, and they include residential or inpatient treatment, outpatient, counseling therapy, pharmacotherapy, self-help or support groups like Alcoholics Anonymous. And we'll spend just a bit of time exploring brief intervention. Brief interventions are effective, low-cost treatment alternatives for alcohol problems. They have many years of successful research to back them up. They're self-help, they're for use with non-dependent individuals, they're time-limited, typically 1 to 4 sessions, and usually performed in a non-treatment clinical setting, but they can also enhance formalized treatment. Brief intervention combines techniques of motivational interviewing and cognitive behavior therapy. Remembering the mnemonic of FRAME, we want to look at the components of brief intervention: feedback of personal risk, responsibility for personal control, advice to change, providing a menu of ways to reduce or stop drinking. One method won't work for everybody, and an empathetic counseling style. Some examples of feedback include, are you saying that I'm an alcoholic? This can be rephrased back to the patient as, what I'm saying is that based on what you've told me, I'm concerned about your health and safety. I'd like to talk with you more about this. Or, you report drinking about 12 drinks each week, mainly on weekends. Did you know that health risks increase for women who drink more than 7 drinks weekly or more than 3 drinks on any one day? These risks include things like breast cancer, etc. The key is a non-judgmental, supportive, but informative framework. And again, not everybody will be able to hear the message. We have to look at an individual's level of readiness to change. Your patients and your clients will be at various stages, whether it's pre-contemplation, not even thinking about making a change, contemplation, thought about it but haven't done anything about it, preparation, really making a plan, picking that quit date or cut down date, action, or maintenance. To help individuals move along those stages to get closer to ready to change, really any screen itself may produce change, readiness rulers help focus the discussion. For example, on a scale of 1 to 10, how ready are you to change your drinking? Adverse events, focusing on adverse events and how small changes can have a dramatic impact can be helpful. Looking at calories, money spent, risk to health. The bottom line is we want to meet the client where she's at. And of course, brief intervention is not for everybody. Individuals who are alcohol dependent, have conditions requiring medical management, or individuals with cognitive limitations. It can, however, act as a screening tool for referral. For additional resources on brief intervention, check out the SAMHSA website. The Treatment Improvement Protocols, the TIP series, are available free of charge. For more information on screening and brief interventions for women, you can check out the Centers for Disease Control and Prevention website at www.cdc.gov. And for more information in general, contact the Great Lakes FASD Regional Training Center. If you're outside the Great Lakes region, check out the CDC website to find the closest FASD Regional Training Center to you.